Hello everybody and welcome to the Bad EM podcast. My name is Daniel Still and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. In this, the final episode of Season 2, I am honoured to welcome the MEC for Health and Wellness in the Western Cape, Minister Mireille Wenger. We explore a wide range of topics, starting with the department's strategic plan for the current term in office. We discuss emergency centres and how to maximise patient flow while improving both patient and staff satisfaction, with a particular focus on bolstering primary and preventative care. Minister Wenger shares insights into some groundbreaking projects currently underway that are already changing lives and going from strength to strength. We delve into public-private enterprises, technological innovation, and how digital solutions are helping doctors and patients in rural areas access easier pathways of care, ultimately reducing the burden on the system as a whole. While this podcast typically has a national and even a continental focus, this episode naturally centers on the Western Cape. However, many of the topics we discuss are broadly applicable across different contexts. Without further ado, welcome to the show, Minister Wenger. Thank you for taking the time out of your busy schedule to join us. Would you mind starting by introducing yourself and giving us some background on your professional career?
Sure. Well, thank you very much for having me on the podcast. As mentioned, my name is Mireille Wenger. I'm the Provincial Minister of Health and Wellness for the Western Cape. I've spent almost 20 years in public service in the province. Before this role, I was the Provincial Minister of Finance and Economic Opportunities. And prior to that, I spent many years in the Provincial Parliament. I served in many roles, Chief Whip. I also chaired various standing committees, including the first of its kind ad hoc committee on COVID-19, which oversaw the work of the government during those difficult pandemic years. And prior to that, I was very much involved in policy development in community safety. So, yeah.
Thank you. And thanks again for taking the time to join us on the podcast. I know you must be very busy. Would you mind running us through your department's strategy that I heard you speak about at a recent conference with regard to the Start Well, Live Well, Age Well, and Run Well 4 pillars?
Sure. So we have a strategic plan that takes us through the term, and we've essentially set ourselves 4 strategic goals. That's Start Well, Live Well, Age Well, and Run Well. And these take us through the life course of a person's journey. Start Well focuses on maternal and neonatal health as well as early childhood development. And in this area, we have 2 of the ministerial priorities, one focusing on nutrition, and we're running a stunting prevention pilot program called Kulisa Care, as well as Planet Youth, which is looking at strengthening social protective factors for young teenagers. The second one is Live Well, is to support adults to live healthy and thriving lives. We're looking at tackling non-communicable diseases, mental health, as well as social well-being. And in here also live another 2 ministerial priorities. So one is looking at our capital build and making sure that we can increase the pace at which we're building physical infrastructure. At the moment, we have 45 projects in construction at a value of about 1.8 billion rand, which is the most number of construction projects that we've had in a single year to date, I think. And then we have...
I'm sorry, just to interrupt, yes. The construction projects, are those hospitals, clinics, step-down facilities, that sort of thing?
It's across the board. It's hospitals, new clinics, maintenance, additional, for example, acute psychiatric units at existing hospitals. So there's a range of different projects included in those 45 in the current financial year. Then importantly, we've added Age Well, which is a new strategic priority, which is looking at how we can help people to age well. The Western Cape is the fastest aging province in South Africa, although we still have a relatively young population. We do need to think about that future and making sure that also our elderly currently are well supported and can age in a dignified manner. We're also incorporating palliative care, which I think is extremely important. Mm-hmm. The final one is Run Well, which is our governance agenda. and making sure that every rand of taxpayer money is used well, and that we can stretch every rand as well, because we are in a resource-constrained environment, and being responsible with the funds entrusted to us. I'm very happy to say, if I'm allowed to say, I'm not sure if the results are, that we've received our 7th consecutive clean audit for the Department of Health and Wellness. I think we're the only one in the country with such a track record, and we'd like to continue with that governance framework. But just to say that where we put all of this together, the purpose of which is to ensure that people can thrive and live a life that they value.
And on those, going along the themes of what you've just said, as well as where I'm coming from in the emergency department. So emergency units are where people not only come in emergencies, as we increasingly see, but for any unscheduled care. And that increases when there's a strain on the primary healthcare system, because people can't access that timeously. So they come and they don't actually mind waiting 15 hours on a chair because they think they're going to get benefit out of that. And it also gets overcrowded when there's a strain on the tertiary care system. If people subjectively think that they're waiting too long for specialist appointments or things like that, or if their conditions actually complicate too early, and then now it's an emergency, whereas before it wasn't. In terms of staff and public satisfaction, as we've seen in the UK, the NHS, whenever it comes under strain in the media, the waiting times in A&E are always one of the first 2 points made. And that is increasingly a problem in the Western Cape with the long waiting times in emergency units. And you did mention acute psychiatric units, which I can maybe ask you a bit more about later, as well as bolstering palliative care services in your plan. What are some of the other measures we're taking to bolster capacity and manage flow through emergency departments?
So, good question, and I mean, it is a challenge that we face. I think the first area is in primary care itself. Is making sure that we can strengthen access to primary health care and reducing strain on emergency centres, especially for what we call green patients that could be assisted and supported at clinics. But also what we're trying to do is to help receive care at home and in communities. So we have a large community healthcare worker program that help in communities, and for patients that need chronic medications, we have the chronic dispensing unit that delivers medicines closer to home. At community centres, chronic medicines are dispensed in communities, which then also takes a bit of pressure off the clinics. In the last financial year, the chronic dispensing unit delivered over 5 million medication parcels. So it gives you an idea of the extent of the program. Mm-hmm. The second area must be around education and empowerment, so that every resident understands which facility or pathway would be best for them at that particular point in their medical needs, as it were. But also we encourage people to use the appointment system because then it can be slightly more orderly. We can navigate staffing based on appointments and so on. It helps us to plan better if the appointment system is used.
And that appointment system, is that the online booking system that you can book your own clinic appointment?
Within the facility. Within the facility, you can book the appointment. And if you do that, your folder will be ready and waiting for you, rather than a clerk having to try and locate your folder in amongst the thousands of folders that are at that particular facility. So that I think that's an important point. We're also looking at empowering communities. So we have quite an extensive EFAR, which stands for Emergency First Aid Responder Program, and that trains community volunteers as first responders as well. So if somebody has a question about whether they should go to the EC or not, we have groups of volunteers that are trained in first aid to support that, and we have about 10,000 trained province-wide so far. And this is particularly helpful in rural communities where perhaps ambulance waiting times are longer. Then I suppose the important one is a focus on prevention and looking at how we can maintain healthy lifestyles as far as possible. We are looking at expanding our WOW program, which is the Western Cape on Wellness. We have almost 1,000 participants already with exercise clubs and eating clubs, and we're looking at how to expand that more broadly in helping people with information on how they can make healthy life choices. Then, of course, as I mentioned earlier, we have a very big focus on our infrastructure and capital build program. So we're expanding facilities to be able to increase access to healthcare in the province. We have quite a number of upgrades and modernization projects ongoing at the moment. We're building a very large clinic in Ravensmead and Hornley. We've just completed Botezig. Deersville is going up as we speak. De Durance, Wellington, Philippi, Strand. And then we have a very large upgrade of the emergency centre at Grooteskiel Hospital. I went to go visit it a few weeks ago, and it's really wonderful. A lot of focus on wellness, natural light, and that's about a 250 million rand project. So once it's done, it will really help to improve access to emergency care.
Awesome, thank you. So there's clearly quite a lot on the go.
It was a very long answer.
No, it's good. It means that you guys are busy, which is what we want to hear and what we want to be reassured by, I think, because I think one of the things from a staff member perspective in the dredges of the night is we think we're the only ones doing something, and I think that's one of the points of the interview is to reassure people that there is something going on in the background. So thanks for all the work that you are doing. Just in terms of the social factors leading to poor health outcomes and how that integrates with the Department of Health and Wellness. And I know there's the Department of Social Development and roads and infrastructure, and all of these sort of mingle together. And often, while not directly responsible, if you have a poor outcomes in the Department of Social Development, it leads to cost on the Department of Health and Wellness. For example, somebody that comes to the emergency unit a few times a month because they have a substance use problem, and then they get very aggressive and intoxicated, and the police bring them here because he's a psychiatric patient, but meanwhile he's not actually a psychiatric patient, he's just aggressive, and he gets discharged in the morning because the inpatient psychiatric team and the emergency team reckon that he's not psychotic, he was just intoxicated. But now we've discharged him into an environment, often without even means to get home, into exactly the same environment that is making him sick in the first place, which is obviously not directly a responsibility of the Department of Health and Wellness, but like you have alluded to, we need to prevent that sort of situation. So how do we overlap in terms of the responsibility and the focus of your department in terms of prevention?
So they often say that health is a mirror to society. And very often the causes of some of the health issues or the issues that we see in our health system are not caused by health, but as you say, in social determinants or other factors in society. So we are doing what we can in a transversal way with departments in the provincial government, but also local municipalities, to try and have a look at how can we prevent some of these issues. We're also partnering, of course, with NGOs and so on. So the first is Planet Youth. So Planet Youth, as I mentioned earlier, is trying to strengthen social protective factors for grade 8s and 9s, because that is a critical age before those children become teenagers and young adults.
And exposed to the many ills of society. They're still sort of half children, half teenagers.
Exactly.
Yeah.
And it's developmentally, it's a good place to put in systems or to put in buffers to make sure they go on a good life course, as it were. So this project was piloted in Thembalethu and George and had very good early signs of success. So we've decided to scale it up massively. It is an Icelandic model that is rolling in around 19 countries around the world with very good success rates. And I think if we can achieve even part of the successes that they've seen elsewhere, we would be doing very well. So the first is to survey grade 8s and 9s and to ask them what's going on in their lives. Instead of government telling them what to do,
they should be doing
and what they should be doing, we're asking them to tell us about what their lived realities are. And we had excellent responses from the grade 8s and 9s. We surveyed 123 schools in 7 areas, which is just under 50,000 grade 8s and 9s, and which gives us a dipstick into a population of around 1.5 million people.
And is that all over the Western Cape?
All over the Western Cape, in 7 geographic areas. We would eventually like to scale up right across the province, but as this first scale up, you can see it's quite significant. And we asked them about their school. Do they like going to school? Do they feel safe at school? Do they feel safe at home, in their communities? What's the deal with social media? Are they sleeping well? Do they drink? And so on. And we understand attitudes and influences. And then based on these surveys, which are anonymous, we can then devise programs in conjunction with other government departments, with municipalities, NGOs, etc. And the idea is to strengthen communities. We will then redo those surveys in 2 years' time and survey the next cohort of grade 8s and 9s to see, are we succeeding in doing that? And there's some very interesting insights, and in particular on substance use. Now, I'll probably get the statistics wrong, but you'll get the idea. In some of the surveys, we realized that parental attitudes towards drinking directly influence whether those young people decided to drink or not. And they're quite significant. It's quite a significant way in which if a parent endorses or doesn't explicitly state disapproval of a grade 8 and 9 drinking, they're more likely to go on and try it or engage in alcohol use. And just presenting that information back to the community was quite a light bulb moment, right?
Glass ceiling shattering, yeah.
And, parents will then say, well, I'm going to be much more explicit in voicing my disapproval of my children drinking.
Yeah.
And, that's a first step, isn't it? But it's also about things like reinforcing and saying, I love you to your child, or putting down the phone when you're spending time with them. There's many, many insights that the surveys help us to help reinforce those social protective factors. So I have a lot of faith in this program, and I think it will do us well in years to come. And because it's at scale, I think it really has a lot of potential.
Just out of interest, are our grade 8s and 9s, I'm sure they're a bit different, but also very similar in a lot of ways to the grade 8s and 9s in Iceland and wherever else they've done this?
That's a good question. I don't actually know.
Because the fundamental things like parental support and shows of affection and things like that are probably quite universal.
Absolutely. And interestingly, our parents are doing very well in the province. Overall, youngsters feel loved and feel safe at home and safe at school. So, there are a lot of positives that have come out of the surveys. And of course, because these surveys are so extensive, we have a province-wide understanding, but we also have, for each of those 7 areas, we have a community-based analysis of what those grade 8s and 9s are telling us, so that we can be quite specific in making sure that we can protect them and give them the best possible chance of a healthy and thriving future. The other one is the nutrition program, which is a stunting prevention pilot program that's on the go at the moment. The department did a stunting prevalence survey about 3 years ago, which found that about 19% of children in the province are stunted, which is shocking.
A huge amount, yeah.
Although our rates are lower than other provinces, when I heard about this, I thought we actually have a moral imperative to do something about this. So we've partnered with the DG Murray Trust, which has been working on nutrition and stunting for many years. as well as Grow Great and ShopRite as our retail partner. And what we're doing is we're targeting underweight pregnant moms and low birth weight babies in the pilot in 3 geographic areas, 1 rural, 2 metro. And we're supporting pregnant moms with vouchers for specific nutritional support. And that nutritional support is based on the World Health Organization's 10 best buys. So with the voucher, you can buy those 10 protein-rich types of foods, and it is followed up with intensive community health worker support twice a month to check in on mom. How is she doing? Is she eating okay? We've developed a recipe book for these ingredients to make them tasty, and obviously clinic check-ins and so on. And we're monitoring that to see if this type of intervention might be the solution to those high rates of stunting in our province.
Awesome. That sounds like exactly what we need. Also, I myself, I've just had a baby.
Congratulations.
Thank you. It was quite close to home when you go back to work and you see small babies, and that's sort of not, they're still within a normal birth weight, but they're just smaller, and that's not necessarily due to anything that the families have done right or wrong, but it just shows how important that nutrition can be.
And the right kind of nutrition.
Yeah.
And making sure that we have the right supplements as well during pregnancy and also afterwards. So the program runs until baby turns 6 months old. So there's help with breastfeeding support once baby's born. And we've also learned that for those families that need to access a childcare grant, it takes about 6 months before the administration of that is completed to be able to receive it. So there is a gap in those first 6 months that this program aims to fill as well, and to make sure that mom and baby can be well fed and nourished in those first 6 months of life. So it's still early days, but we have good knowledge partners that are tracking and monitoring how we're going, and we should have some early results by about this time next year.
Awesome. So moving on, in terms of pathways of care, mostly in terms of geographical context, there seems a lot of patients worldwide, but speaking for these purposes province-wide, go through very complex pathways of care and go to different hospitals for different investigations or specialist clinics. And that is costly for the patients and for the healthcare system in terms of transport and redundant work. When people are doing the same work twice, the information is lost along the way a lot of the time. And a lot of the time also people go for negative tests. So people go all the way to Grooteskiel or Tygerberg for a CT scan, and it's a negative result, which is obviously a good thing. But then they go back home, and then that cost is not always necessary. How can we decentralize these complex care pathways, either by making information more readily available, empowering primary care physicians and nurses to make more decisions to minimize those unnecessary transfers, as well as perhaps the investigations themselves becoming more readily available?
It's something that we are thinking long and hard about, and we need to do a lot of enabling work to improve on that. And one of those things is digitization. So we have to work as quickly as possible to digitize health records, because that will enable, local medical officers to access results and things like that, which would save the patient from traveling long distances to access those results or for follow-ups, etc. And we need to see how we can make our various systems interoperable to make that as easy as possible. We are also looking into AI. Mm-hmm. And there is one program currently running in Kailicha, which helps with, it's a diagnostic tool basically at 4 primary healthcare clinics, and it's to detect diabetic retinopathy. Mm-hmm. And it's a screening tool, and if it is detected, it automatically books that person in to an appointment with a specialist at the district hospital. So it saves a few additional visits for that patient and gets them into specialist care faster.
Appropriate specialist care.
Yes, exactly.
Because a lot of the time, these specialist clinics are overbooked with inappropriate care that can be managed at a primary facility. Yeah.
Exactly. So this pilot is working very well, and that is one way in which technology can help to do that. So at George Hospital, we have a double robotic device called Georgie. And Georgie is a piece of technology that connects the doctors at George Hospital with specialists at Grooteskied. And Georgie can move around patients. It's mobile. And with a medical officer in the room to consult with the specialist at Grooteskied who can have a look and see, because the cameras are extremely advanced.
Does it look like an actual robot?
It looks like an iPad.
On wheels.
On wheels, yes. And that means that either the patient is safe from having to travel, 500 kilometers each way to seek specialist help, or the specialist having to travel and so on. And that has really been quite an innovation that is also helping to increase access to care. And that is something we'd like to explore for other areas as well, and to see if we can integrate that elsewhere. The other is we're looking at how do we partner with the private sector. And I'll give you a simple example in imaging. Many of our a few of our district hospitals in rural areas don't have specific imaging technology like a CT scanner. So what that means is a patient that requires that scan needs to be put into an ambulance and sent to the metro for the scan, which takes an ambulance out of circulation for several hours. And also, it's not great for the patient experience. Is there a way that we could partner with the private sector to access imaging services closer, if they exist in those rural areas? And you can see that would solve a lot of time. It would also help EMS, and I think it would be much better for the patient experience.
Yes.
Telemedicine is also something we're doing and looking to expand. I think there are many global examples of how this has been very successful. So these are all things we can do, and we're looking at how do we do this in a way that strengthens the health system generally, and what are those things that we need to do to enable them?
You mentioned public-private enterprises, which initially in my question I wrote as public-private partnerships, which I believe is something different.
Yes.
So for non-political folk, would you mind first just clarifying the difference between that? And then secondly, so what are some of the pros and the cons of working in partnership with private companies? And in what situations does the government feel it better to create their own systems modeled on private innovation as opposed to outsourcing to private companies?
Okay, so generically speaking, there are partnerships. Then there are partnerships between the public sector and the private sector. And then there are public-private partnerships with capital letters. So a PPP with capital letters is a financial and legal mechanism that is managed by the National Treasury. And it has very strict requirements in how it can be established and managed.
Yeah.
And it has several stage gates that have to be met on sustainability and other legal requirements for it to be formally established. This is something that we're exploring for the Tygerberg Hospital redevelopment, for example. And it does take very long, but it is a specific type of mechanism in which a public institution and a private sector partner deliver a service or a project, and it's formalized. Then we have, for example, relationships with NGOs or trusts, or a private sector company in which they may donate some infrastructure or training, and we collaborate with them by providing the staffing, etc., like we have done very successfully with some of the hospital trusts, like the Red Cross Children's Trust and the Grooteskied Trust. Recently, the Red Cross Children's Trust built a burns unit at the Ceres Hospital, and our staff received additional training for the use of the equipment and to be able to provide care for children, pediatric care at the Ceres Hospital, which brings care closer to home. Again, so children don't have to travel all the way to Red Cross to receive care or to have their dressings changed for their wounds, and also the burden that travel places on parents. So that is a type of partnership which we're actively engaged in many different ways. We also have established a think tank with the private sector where we have all the big players involved, from hospitals to pharmacy associations, doctors associations, academia, and so on, where we're thinking about how can we collaborate as a healthcare sector in general. And we're looking to co-create a UHC strategy for the Western Cape. And how can we combine our knowledge?
What's a UHC?
Universal Healthcare Strategy.
Yeah.
So if we all work together and combine our efforts, which very often are duplicated or in some areas underutilized and in others overutilized, if we were to look at that in a way that made sense for all of us, what would that look like? So that's the work we're currently doing through the think tank. And we're sort of mapping some of the existing partnerships to see what has worked and what hasn't worked, and can we take learnings from those to apply to the broader strategy that we'd like to see in our province.
So when it comes to linkage with a lot of different stakeholders, when it comes to policy and protocol formation, and also importantly dissemination thereof, could you touch on the relationship between governments, university, faculties, clinical departments, and obviously the private sector and NGOs, etc.? And how do we all get on the same page? Because this comes from a subjective feeling sometimes at work in the emergency unit, where we get a lot of policy that gets made above our heads, but at the same time we don't ever see any public health physicians at the hospital or in the unit when there are 60 people waiting for a very long time. And then it feels like a lot of the policy, and I know this is different with our heads of department and hospital management and things like that, the communication might be the issue, but we often don't feel like there's much engagement between different stakeholders from our perspective.
So there's various things sort of in the works. From a strategic level, we have something called the JAG, which is the Joint Agreement Governance Council, which is a meeting we hold annually with myself, the head of department, and the vice chancellors of the 4 universities in the province. And that is a mechanism to make sure that we continue to build a good working relationship between public health and the universities. And I must say it is a very strong and well-embedded relationship, which I was delighted to learn about and to see in action. A lot of collaboration and coordination between academia and public health. Then there are working groups with the head of department, Dr. Klutty, and the heads of faculties, and they also look at some of the issues in public health and in academia, and how can we work together to solve some of these issues. Dr. Klutty also does regular, what he calls ecosystem visits, where he'll go with the entire management team to a specific area or hospital and go and see what is going on, what are some of the challenges, what are some of the fantastic innovations coming out of the public sector, and to see how do we solve some of these challenges and how do we replicate the innovations. And this is a continuous feedback loop then again with academia. And we have several joint appointments between the universities and the department itself. So there's a continuous kind of cross-pollination between the two, which I think ensures that we have a robust public health system, and also one that is continually evolving and looking at best practice and what's coming out of academia. On the policy front, I mean, I think there should be mechanisms for engagement and to see what's working, what's not working. And I think there are surveys from time to time, but if there are specific policy challenges, I mean, I think it's important to raise those with the heads of the department in the areas in which you work to kind of raise those, because we like to have debate and discussion and to continuously improve.
Yeah, and obviously it's important for you to get that feedback, because it's a two-way street. If something is working or not working, we need to make that known to all parties, and that can be difficult, or sometimes it's just not done. We just grumble.
Yes. Communication is very important. Yes, I agree.
One more thing that I would just like to ask about, since I didn't know it was happening, was the acute psychiatric units. What could you explain what those are and what the gap you're trying to fill and what is happening with that?
So we are currently building 3 acute psychiatric units, one at Kailita District Hospital, one at New Summit Hospital, and one at Easter River Hospital. They're almost complete. I'm hoping to be cutting ribbons imminently.
I think you've cut quite a few recently.
And these acute psychiatric units have been very carefully designed to make sure they meet patient needs and patient safety. Mm-hmm. Each of the APUs, as they're called, has 30 beds, and they have male and female sections to make sure that patients that have acute psychiatric needs can be cared for in the most appropriate way. Because we know that in some instances in the general ward, it is a bit challenging. And by having these acute psychiatric units, we can offer a better level and safer level of care for patients that have acute needs, and make sure that younger patients are also protected and cared for in the appropriate way.
And just to clarify, would a self-recognized or an EMS-recognized psychiatric complaint go straight to one of these, or would they go to an emergency unit and then to one of those?
Yes, I think they'd follow the usual pathway via the emergency centre.
Yeah.
And then into the APU.
And that would be managed by the psychiatric department at said hospital?
Yes.
Okay.
And they're, perhaps you'd like to come and visit one. There's been a tremendous amount of thought in the design to make sure they're as safe as possible. Also, a lot of natural light. Really, I think there really has been a lot of thought into making these as fit for purpose as possible.
Yeah, because as we mentioned, there are a lot of problems with the amount of psychiatric patients that are sitting in emergency units and general wards in the hospitals, and they, most importantly, they're a vulnerable population that get over sedated and then wake up and get overly aggressive, and which is a safety risk for themselves, for the other patients, and for staff. So to build that capacity, I think, is very important. And then on to my last question. If you had a magic wand and you could wave it and something would materialize for healthcare and wellness in the province overnight, what would that be?
If you find this magic wand, so I've thought about this, and I think if I did have a magic wand, it would be to have a much safer society. So we had much lower levels of interpersonal violence. I think that would almost immediately take strain off emergency centres, the mental health burden that comes from trauma, not only from people that get hurt, but for those that witness it or who are affected by family members that have been injured or murdered. I think that would be the thing.
And as we alluded to, that's a very that would be lovely if you had a magic wand, but it's a very complex thing to get.
It is indeed. That's why I wish we did have a magic wand. But we do have a lot of programs in place to try and reduce violence and to prevent violence. As a health department, we're operating in the violence prevention side in some of those programs that I spoke about. We also need to reduce violence, and hopefully in time, with both of those things running at scale, safety or an increase in safety will materialize.
Let's hope. But yeah, thank you so much for joining me, and I really enjoyed that conversation. So thanks for taking the time.
My pleasure. Thanks for the opportunity.
That's all for this episode, and what a fantastic way to wrap up Season 2 of the Bad EM podcast. Let's quickly recap what we discussed. We explored the 4 pillars of the strategic plan: Start Well, which incorporates the Kalisa Care program in collaboration with the DG Murray Trust and ShopRite; Live Well, with special mention to Planet Youth and the Western Cape on Wellness program; Age Well, expanding palliative and home-based care services; and finally, Run Well, celebrating a 7th consecutive clean audit of the department. We spoke about emergency centre flow, focusing on prevention and bolstering primary care, where we learned about the huge infrastructure projects underway and the EFAR program, which aims to strengthen community education and first aid. We discussed the digitization of records, AI screening for eye issues, possible outsourcing of CT scans, and the innovative Georgie the robot, all of which make physical distance less of a constraint and patients' healthcare journeys less arduous. We also touched on public-private enterprises, including work with the Red Cross Children's Trust and the Groote Hospital Trust, as well as a new think tank bringing private and public stakeholders together to share common developmental goals. You'll find links to the partner projects we discussed in the show notes below. Feel free to reach out to them directly if you'd like to learn more or get involved. And if you'd like to contact the Minister's Office, you are welcome to email healthadmin@westerncape.gov.za. As I mentioned, this is the final episode of Season 2. We'll be back in a few months with Season 3, which we can't wait to get started on. Thank you for your continued support. And as you may have seen on social media, we've crossed the 10,000 streams mark across 72 different countries. A big thank you from us to you, wherever you may be listening from. Be sure to rate, review, and subscribe on all of your favorite platforms, and share the podcast with a friend or colleague who might be interested. If you'd like to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Follow us on Instagram and Facebook at Brave African Discussions, and on X or Blue Sky as Bad EM. Thank you for listening. See you in Season 3. Bye bye.